So today, my topic will be on Alzheimer's disease and mild cognitive impairment. And as we go through, I'll be talking about the clinical presentation, the underlying neuropathology, give you an idea of how the disease actually, where it starts, how it spreads, and what the cognitive ramifications are. And we'll also then finish up by looking at some more current characterization methods that are currently being proposed by the National Institute on Aging and the Alzheimer's Association. So with that, there are no conflicts of interest to disclose. My own personal work has come from multiple grants from the Department of Veteran Affairs, and as you know, this is part of a series of recordings sponsored by the Michigan Alzheimer's Disease Core Center, and which is an NIA-funded grant. As I mentioned, the overview here, part one, we're just going to go through the cognitive and neuroanatomic changes that occur with normal aging. And I throw normal aging in here simply because it provides the background, the context on which any disease is superimposed. So we know that there are certain cognitive and neuroanatomic changes that occur. And so when we think about disease processes, those are occurring in addition to normal age related. So I think it's important to at least have a very, very brief overview of what those normal, quote unquote, changes look like. I'll then go into Alzheimer's disease and mild cognitive impairment and talk about the diagnostic criteria, as well as the neuropathology and our ability to now detect the neuropathology in vivo. And then we'll wrap up, as I mentioned, by talking about future characterization approaches that look at the different, that utilize the different biomarkers to help assign levels of certainty in our diagnostic process. To give you a brief overview of some of the disease-relevant neuroanatomy, if we take the average head, which is shown here, and we give you X-ray vision, you can see that there's the brain within the head. And you can see the approximate location of the brain relative to the ears and to the eyes and nose and the top of the head. The brain has four lobes: the frontal, the parietal, the occipital, and the temporal. And the disease pathology, as we'll go through in a little bit, begins in certain areas of the brain, and that's really what then causes the cognitive and behavioral symptoms that may emerge. Now we know that this lateral frontal parietal network works very closely with, these areas are very closely combined and are part of the same general network. We also know that the disease begins very early on. Disease accumulation is evident in the medial parietal lobe. And so this may fit within some of the larger cognitive neuroscience research showing that there's a reduction in both metabolism and in functioning of the parietal cortex, as well as a potential upregulation of the prefrontal cortex that may suggest a potential compensatory mechanism. That's a talk for a different time, but just want to relay that information. One of the critical structures of the brain, if we think about the disease process of Alzheimer's, and the key cognitive characteristic of learning and memory deficit, is the hippocampus, which you can see here as I move the cursor back and forth over this kind of greenish area in the temporal lobe. Now, in the bottom figure here, I've removed the left hemisphere, so you can see the right hemisphere, you can see the right hippocampus, as well as the left hippocampus. And you can see that this structure is not terribly large, and if we take a little bit of a bigger look at it, what we can see is that if we chop the head at about the level of the ear and I rotate the head toward you, here's a two-dimensional slice of the hippocampus. Here's the right hemisphere that's unaltered. And again, these series of images give you an idea of where the hippocampus is and how big it is. And as you can see, it's really not very large. As with most structures in the brain, or pretty much all the structures in the brain, it's bilateral in nature, meaning that there's one in each hemisphere. This area is absolutely critical for our ability to learn and remember new information. It's also an area that's affected very, very early in the course of Alzheimer's disease. And so again, here it is just within the context of the brain that I showed you from that last slide. And in that last slide, you may notice that there was an arrow showing that it interacts with that lateral frontal parietal network during the learning and remembering process. So in Alzheimer's disease, medial temporal lobe structures, including the hippocampus, are affected early on. And so before we come back to the way in which the hippocampus and other medial temporal lobe and other brain structures are affected in Alzheimer's disease, I think it's first important to establish the normal changes that occur with aging. And so this figure here comes from a relatively older review by Salthouse and colleagues. It's now about 7 or so years old. And you can see that there are two basic patterns here. One that you see is slightly increasing, if not stable, across the lifespan, and then the others that show decline across the lifespan. Now, this stable profile is really what's traditionally been called, quote-unquote, crystallized abilities. So this is our general fund of knowledge, our semantic information, things that we learn across the lifespan that we're very unlikely to forget until very late in a disease course or with a very severe brain injury, for example. These other abilities, you can see that they all decline over the course of the lifespan. And these involve things like our reasoning ability, our processing speed, our spatial abilities, as well as our episodic memory. So I just mentioned that our semantic knowledge is stable, if not improving, over the lifespan, but our episodic, so our memory for contextually rich information that makes our memories ours. The Thanksgiving holiday that we just had, and remembering sitting with your family and the sights and smells and the conversations, that's fundamentally different than knowing that a giraffe is a type of animal. So those episodic type memories decline across a lifespan. Those are also some of the types of memories that are absolutely affected very early in the disease course of Alzheimer's. So as I mentioned, the semantic or crystallized abilities are stable, whereas more fluid abilities, as we discussed, decline over the lifespan. Now, one important caveat here is, as I talk about the biomarkers, a lot of the work that we know about normal, in quotes, aging, comes from pre-biomarker work. So people were assumed to be cognitively intact, to be healthy, simply based on their cognitive phenotype of being preserved, or intact cognition. Whereas now, as we'll talk about, the disease process, in this case Alzheimer's, starts years, if not decades, before symptoms emerge. And so there's increasing interest in looking at subtle cognitive changes that may actually suggest different patterns. And I think this is an area that's starting to gain recognition in the field, and that may let us reevaluate what is actually normal aging versus early pathologic aging. So, as I mentioned, the brain also changes, and this is a nice study that Naftali Raz and colleagues did several years ago. That's just one such example where they followed cognitively intact individuals over a period of years, and they observed multiple changes where somewhere in the mid-50s, there appeared to be an inflection point where decline began and increased. And some areas appeared especially sensitive to vascular disease, such as the hippocampus. So if we look at this table of the different brain regions that they examined that showed change, and we look at the effect size of that change, we can see that some of the biggest effects were found in the prefrontal white matter, which is basically the wiring of the brain. It allows the brain to communicate efficiently, the different brain regions to communicate with one another. Also, the prefrontal cortex here changed, as well as various regions within the inferior temporal lobe. And as I mentioned, the hippocampus was also one of those areas showing change. And this just gives you a sense of where people were in each of these pairs of lines as an individual participant. And if you look at the overall slope of the line, extrapolating from all these different points, you can see that it certainly has a downward trajectory of hippocampal decline across the lifespan, both within and between individuals. So one question that we often hear is, does Alzheimer's equal dementia? And the answer is yes and no. Dementia is the clinical phenotype, the clinical presentation of symptoms, whereas there are a lot of different subtypes of dementia that have different etiologies. And so here You can kind of think of dementia as an umbrella, and then each of the spokes or even the handle as being a different type of dementia. And so we have Alzheimer's, we have frontotemporal, we have Lewy body, vascular dementia, Parkinson's disease with dementia, Huntington disease, prions, and on and on. So these are just some of the big ones. And again, today we're going to be focusing on Alzheimer's disease. So when you hear the term dementia, that's a fairly non-specific general description of somebody, and we'll come back to the specific definition in just a minute. But as this figure from the Department of Health and Human Services shows, Alzheimer's disease is by far the most common type of dementia. Now, you'll also notice in here that there are a lot of mixed dementias, and that's an area that's certainly gaining additional traction because a lot of brains don't just have Alzheimer's disease. A lot of them have vascular disease or mixed Lewy body or other type of pathology that's affecting the clinical presentation. And the Alzheimer's disease currently says that there's a prevalence rate of Alzheimer's of about 5.4 million Americans, which equates to about 1 in 9 over the age of 65 years. They also, though, estimate that up to about 16 million older adults will be affected by the year 2050. And this is part of the national strategy to combat Alzheimer's disease that you may be hearing a lot about in the media these days. So as I mentioned, Alzheimer's disease is the actual disease process. It's the accumulation of beta amyloid and neurofibrillary tau plaques within the brain. This is distinct from Alzheimer's type dementia, which is a clinical diagnosis that requires impairment in multiple cognitive domains and functional impairment that's characterized especially learning and memory, aspects of language, and executive functions that, again, we'll come back to in just a little bit. Now, the term mild cognitive impairment, again, I'll come back to a little bit later in the talk, but MCI is an actual diagnostic category that's meant to convey this gray area where somebody is not functioning normally based on history for them, but they also haven't progressed to Alzheimer's type dementia or official dementia diagnosis. And so they're kind of in this gray area. And again, we're going to come back to that, but I just want to set the stage right now. Now, the diagnosis of dementia due to Alzheimer's disease in 2011 had its first revision in roughly 25 years. And so in this paper that, again, I've provided the references for those of you interested that you could go and look it up, the authors first established criteria for all-cause dementia, which is cognitive or behavioral impairment in at least 2 domains. So things like attention, learning and memory, problem solving or executive functioning, language abilities, visual spatial functioning. It has to also then individuals to meet the criteria, in addition to the cognitive or behavioral impairment, also have to show functional impairment. So they're not able to do well in their everyday life, whether it's at work, whether it's social situations, what have you. They're showing functional decline. This has to represent decline from a historic level for that individual. And it can't be accounted for by something like delirium or a major psychiatric disorder. The criteria for probable Alzheimer's disease is that it meets the all-cause dementia criteria. There's an insidious onset over months or years. There's a clear history of worsening in cognition, as I mentioned, that's supported by subjective report and or objective evidence if you have, say, serial neuropsychological evaluations. And there are several recognized variants where, as I mentioned, learning and memory, or the amnestic presentation, is by far the most common. There's also a language presentation that's characterized by word-finding difficulty, and that is thought to be kind of more of a logopenic primary progressive aphasia. There's a visual spatial presentation that consists of difficulty with spatial cognition, object agnosia, face recognition deficits, simultaneagnosia, and alexia. And this is often associated with posterior cortical atrophy. There's also the frontal variant, or the executive presentation, which affects reasoning, judgment, and problem solving as some of the early symptoms. And that later presentation can often be difficult to dissociate from a frontotemporal dementia. Now, these criteria in 2011 began to integrate biomarkers in order to increase the etiologic certainty. And so I'll refer you back to this original paper so that you can go in and really read in a lot more detail than I could provide in this overview session. But we'll come back to where those criteria currently stand in relationship to some of the integrating these biomarkers toward the end of the talk. This is a nice review from Backman and colleagues that, again, is about 12 or so years old now. But they did a meta-analysis of preclinical Alzheimer's disease, so those in the earlier phases of it. And so, as I mentioned, memory deficits, learning and memory deficits are certainly the most common. And so their data support that you can see deficits not just in the retention of information, which from a neuropsychological standpoint is kind of the hallmark that patients rapidly lose information. And while delayed memory or long-term memory, quote unquote, is more affected than kind of the initial acquisition of that information, you can see that there's not a tremendous difference. It is statistically significant, but what I take from this is that this is a very large effect size, showing that the acquisition of new information is significantly affected early in the disease course. So it's not just that patients lose information, it's that they also have a very difficult time acquiring it. These deficits are relatively more evident when we're using recall formats, so when you ask a patient to recall what you just told to them, as opposed to giving them multiple choices to kind of recognize if they had seen the information before. But again, this is a pretty large effect size, suggesting that even recognition is not, certainly by no means fully intact. The deficits, again, were more commonly observed or slightly more observed when using verbally based information than nonverbal. But one of the caveats again is that these are very similar effect sizes, and at the individual patient level, it's probably going to be difficult to really clearly dissociate these time and time again. But while memory is one of the defining features of Alzheimer's disease, what this review also showed us is that global cognition, whether it's an ADAS-Cog or a mini-mental or a DRS, is also at least comparably, if not slightly more affected early in the disease course. And similarly, processing speed and executive functioning were two other big ones, all of which had huge effect sizes over 1. And so this, depending on where these samples were drawn, a lot of our patients typically present to the clinic once they've noticed cognitive problems. And so there could be a selection bias as opposed to more community-based samples, and there's a lot of other work in the field that focuses on that. But again, my take-home message is that just because memory is the most common doesn't mean it's the only thing that's affected. Now, the neuropathology associated with Alzheimer's disease, as I mentioned, there's beta amyloid, which this is a classic Bracken-Brack staging model that you can see in the early stages begins in the limbic system and the entorhinal cortex throughout the inferior temporal and medial frontal, and this gradually spreads across additional brain structures and brain regions until the bulk of the brain is really subsumed, with the primary motor and somatosensory cortices being relatively unaffected compared to a lot of these other areas. Same thing with the tau deposition, where the early stages are really within the transentorhinal region of the medial temporal lobes. And then that kind of spreads out to the limbic system and this medial frontal and posterior regions until, again, the tau spreads and encompasses the bulk of the brain. As I mentioned, hippocampal or medial temporal lobe atrophy is characteristic, and this is a kind of classic work by Jack and colleagues that's now 20 years old, where if you look on the left here, there's a cognitively intact individual, and they've outlined parahippocampal gyrus and hippocampus. And when you compare the healthy control with the MCI patient, you can really see that there's increased ventricular size, reflecting the atrophy in the medial temporal lobe structures in the patient with Alzheimer's disease. But it's certainly not limited here, because some of the other things that stand out are just kind of the sulcal widening and the gyral thinning. relative to the healthy older adults. And these are, again, classic findings that have been replicated time and time again. I mentioned that in the past, Alzheimer's disease could really only be definitively diagnosed post-mortem. So after the patient died, doing an autopsy and staining the brain and looking for the amyloid and the tau. But in the past decade or so, there's been several major advancements in our ability to actually visualize these. And so some of the early work came from PIB, the PIB compound, the Pittsburgh Imaging Compound B, that binds to beta amyloid. There are now commercially available ligands that do this. And so this is an example of one from this group that actually showed the amyloid deposition in the brain of a patient with Alzheimer's. Similarly, just in the past couple of years, there's been major advances in our ability to use PET ligands to bind to the tau. And so this, again, is a nice image showing that we're able to detect that tau pathology in living individuals. So now we've kind of moved from relying on the clinical phenotype to being able to use both imaging and CSF biomarkers in order to increase our diagnostic certainty. And so as you may imagine, if the disease is in the brain, and I've already showed you the volumetric changes, a number of studies have used both volumes as well as cortical thickness. And so this is work from Dickerson and colleagues suggesting there's a cortical signature pattern of atrophy in those with Alzheimer's that, as you can see, a lot of it mirrors the disease pathology in those with Alzheimer's. And so we're really, from an imaging standpoint, at a stage where, especially at the group level, we're able to use these techniques to enhance our diagnostic certainty, and even studies like the A4 trial to select participants who may benefit from novel pharmacologic agents. This is one of the initial efforts by Jack and colleagues to kind of characterize the progression of the disease in Alzheimer's. And so if you think about the x-axis as time and the y-axis as a severity of the disease process, you can see that amyloid, according to this follows the amyloid hypothesis, that amyloid comes on early in the disease course, even when somebody is functioning very well. If we look at this level, and this is our normal cognition level, they're doing just fine, but amyloid is on board. And so there's evidence now showing that the amyloid starts to accumulate 10, if not longer, more years before symptoms emerge. And there's some evidence, at least based in this model, that CSF measures of amyloid may be slightly more sensitive than amyloid. At the time this was published, the tau tracers that I just mentioned had not come on board yet, and so again, it's then tau following amyloid. This again follows the traditional amyloid cascade hypothesis. As well, then later, measures like MRI show the volumetric change, or FDG PET shows the hypometabolism that characterizes the disease process. And then finally, those are followed by cognitive impairment. And we know that cognitive impairment is more tightly bound to tau deposition and tau severity than it is with amyloid. And so as those progress and as their levels increase, we start to convert over to this mild cognitive impairment or eventually to dementia. Now, the diagnosis of mild cognitive impairment, also in 2011, Albert and colleagues came out with a revised set of criteria that are very similar to what Ron Peterson and colleagues at the Mayo Clinic have used since 1999, where really the criteria, the cognitive and clinical criteria, are that there's cognitive concern reflecting a change that's reported by the patient or an informant, or in this case even a clinician, if the clinician knows that individual, that suggest a decline relative to historic or previous observed levels of functioning. We require objective evidence of impairment in one or more cognitive domains. And again, from an Alzheimer's standpoint, this typically involves learning and memory, and really relying on neuropsychological tests to help establish the presence and severity of these deficits. But importantly, participants or patients with MCI are doing pretty darn well in everyday life. There may be some relative difficulties that they're starting to have depending on the severity of their cognitive impairment, but overall, they're still functioning well, and many of our patients actually are still working. And of course, by default, they can't be demented, quote unquote, or have dementia. So again, as with the 2011 Alzheimer's criteria, these criteria started to integrate biomarkers to help with assess level of certainty. And again, I refer you to that original work if you're interested in learning more about that. The biomarkers, as I mentioned, could be things like CSF, PET imaging, volumetric change, the FDG, and so on. I'll give you a second to look this list over. So here, again, were some of the first efforts where if the participant met those core clinical criteria, but you didn't have access to or you had non-definitive evidence of amyloid or neuronal injury, the tau, then the biomarker probability was uninformative. But then you can see that you could assign an intermediate likelihood that MCI was due to AD if you had evidence of atypical amyloid or of tau. High likelihood would be that both were positive, or that MCI was unlikely due to Alzheimer's, being if both of these measures were negative. And so there we would start looking for cognitive symptoms that are non-amyloid or non-Alzheimer's based. MCI increases the risk of dementia with, you can see global estimates and clinical samples and so on. And I believe that Peterson in 2004 had roughly an 80% conversion rate over a 6-year period where MCI patients then progressed to dementia. But again, I'll refer the reader to those original works. We know that on a year in, year out basis, a large majority of those with MCI remain stable. And there may be some fluctuations where some years they are only demonstrating memory deficits, and then later on they'll develop deficits in other areas. Or they may have deficits in, say, language one year, but not another year. And so we see some degree of bouncing around in a large number of participants. But Lowenstein and colleagues have done a number of studies kind of looking at the diagnostic criteria and these reversion issues, or even the sensitivity, depending on how we apply diagnostic criteria. And I'll certainly refer the reader to their great work in doing that. Similarly, Mark Bondi out at UCSD received the 2015 or 2016 Paper of the Year Award for the Journal of Alzheimer's Disease, and I'd encourage you to look at that. Edwards is the first author, and that provided a different approach to diagnosing MCI due to Alzheimer's disease that seemed to be a lot more sensitive to biomarkers, underlying biomarker profile. So again, I'll refer you to those. Okay, and as the final part of the talk here, I do want to transition into some of the current line of thought as far as using the biomarkers to, again, characterize individuals. And so this is some criteria initially proposed by Jack and colleagues that I've alluded to before, and that's similar to what we just talked about with MCI, but it's getting a little more specific in how it can be applied. And they're trying to really develop more stages of Alzheimer's disease. These criteria are currently being finalized, and the NIA has had a couple of different meetings, including at the 2016 meeting of the 2017 meeting of the Alzheimer's Association in London, where they presented these criteria for comment. So what they do is kind of rely on the clinical phenotype as the first level of entry. So again, these would be cognitively intact individuals. And then you use some method of assessing amyloid, tau, and neurodegeneration. And so amyloid, again, CSF or the PET ligands. Tau could be a CSF or PET ligands. And neurodegeneration would, for example, be MRI-based atrophy. And so in clinically normal individuals, if they have different biomarker profile. So in this case, the A is amyloid, T is tau, N is neurodegeneration, and the plus means that it's present, the minus means it's not present or that it's absent, or at least not at pathologic levels. Then you can characterize that individual's biomarker profile. So here we would have a cognitively intact normal person who is biomarker free, at least as it relates to the AD biomarkers. This person would have amyloid, but not tau, and no evidence of neurodegeneration, and so they're proposing this be called kind of the stage 1 of the Alzheimer's process. And then stage 2/3 would be if there was evidence of both amyloid and neuronal injury as reflected by either the presence of tau or neurodegeneration. And obviously then you could have all three or some other combination herein. And again, I'll refer you to the paper to really read through these other options. There's also the criteria for, again, those core clinical criteria for MCI and characterizing people the same way. And as we talked about just a minute ago, that if somebody had cognitive symptoms but was biomarker free, well then it would be MCI that's unlikely due to Alzheimer's disease. Whereas if it was amyloid positive, well then certainly this could meet the core clinical criteria and be kind of a typical AD presentation, and so on kind of down the line here. And finally, for somebody who has probable Alzheimer's disease, referring back a few slides to those criteria that I presented, again, we can use this profile to kind of determine our level of confidence that Alzheimer's disease is the actual primary underlying etiologic factor. So that really covers our overview of Alzheimer's disease and the clinical stages associated with that. I'd certainly encourage you to look at the other recordings within this module, and I've outlined those here. Thank you.